Welcome back, everybody. Mike Hislop for Orlando Medical Institute TV. We're going to continue on with part 2 of Chapter 30, Bleeding Control. And we're going to jump right in. Here we are, scene size up, right? So first and foremost, we have to make that delineation or that determination if there's bleeding. Is it something we can visibly see? So I don't mind bleeding I can see when I arrive on scene because it means it's easily and likely easily controlled, right? What should you be wearing? Anytime there's arterial blood on the table, as is the case with most trauma, you have to have your gloves. You got to have a mask, got to have eye protection, got to have a gown. Be dressed appropriately. If blood is spurting at you, gloves alone aren't going to get it done, right? You don't want that in your eye. You don't want that in your mouth. So obviously, we have to protect ourselves to the likelihood of what we're going to find. High energy mechanism of injury means everything's on the table, right? Your MOI is everything. Trust it. It can't lie to you. It won't lie to you. It has no agenda, so trust it. If the mechanism is real bad and your patient doesn't look so bad, just assume that they don't look so bad yet. Right? That's the way that we can get ahead of that shock and be much better at predicting injuries before patients have to physically look bad for us in order for us to see things. Determine the amount of blood. Human beings are not good at that, right? We put a few drops of blood in a toilet bowl, it looks like somebody exsanguinated. So when you add fluid to blood, put fluid on the ground, if you donated blood, it's 500 cc's. If I dumped that all over the ground, you would think, my God, someone's bled to death, right? But yet you're just fine. So it really comes down to try to estimate best you can based on surface area and how much blood loss over what period of time. Because we know rapid blood loss is actually quite bad, right? Get your AVPU, do your primary survey. Nothing's going to change here, right? Manage those immediate life threats, and they are going to be that arterial hemorrhage, that airway control issue, that breathing assessment. These are the things you have to handle in the primary survey. That's why it's in airway breathing circulation. Make sure you're doing your disability. Make sure we're exposing our patient quite quickly so that we're not missing something major in the primary assessment, but also keeping in mind we got to keep these people warm. Because we do that, patient with terminal hemorrhage needs rapid transport. We're going to identify that right away based on palpation of the abdomen, ecchymosis that we can see, tachycardia, we're already losing pressure. These things are going to be surveilled very, very quickly, and they have to be handled quite quickly. We can't definitively stop bleeding in the abdomen or in the chest, but what we can do is identify it quick and make sure they're getting to the right place. Late signs, weakness, fainting, loss of consciousness, dizziness, dull in eyes, altered level of consciousness. This is late. These are all people with like the worst of prognosis because they've lost so much blood already. So we have to understand that best to find those early signs of shock, not the late ones. Anxiety, right? Simple tachycardia can be that first and foremost, those early signs. Make note of your complete assessment. Make sure we're prioritizing our management, making certain that if interventions are necessary in the primary assessment, that we're staying with them and we're monitoring those for improvement. Because if it's life-threatening things we find there and we address them and we don't manage the surveillance of them afterwards to find out if our interventions are worked, then we haven't really done our job. Internal bleeding, hey, if you stopped all the bleeding on the outside and your pressure is still going down and your heart rate's going up, there's more bleeding, right? It's on the inside, and it's probably something that you can't physically see. Is there dizziness? Is there syncope? Are they on this is where that good sample comes in, even in trauma, right? Or any bleeding, right? Are you on Coumadin? Are you on Plavix? Do you take aspirin every day? Do you have any other clotting problems, right? Are you hemophiliac? Do you have beta blockers? Are you on calcium channel blockers? Antidysrhythmics? Do you take nitroglycerin? It's going to vasodilate. It's going to have, you're going to tell it, hey, this pump's not so good to begin with. It can only be asked to do so much in compensation with tachycardia. So it's going to give you that higher, better surveillance risk as to what to expect in your patient. Look at that abdomen. Make sure they're not bruised or guarding or have rebound tenderness. All these things that are going to give us indications that we have an issue. Pain and swelling. Even deformities to joints and extremities, we know that orthopedic injuries can be associated with bleeding as well, so we have to surveil for that as well. Look for any additional hemorrhages that may have been missed, or even and address that oozing stuff, and even get the rest of the sites dressed up in the secondary assessment. And notice the characteristics, right? Is it capillary, venous, or arterial bleeding? Certainly. I hope by secondary that arterial has already been handled because you probably lost too much otherwise. Hematomas forming under the skin, a large collection of blood that forms, ecchymosis or bruising, that's that deep bruising, but it hasn't had that big surface kind of stuff. Melena, that's that blood and stool, that dark tarry stuff. Hematuria, blood and urine. You took a big flank hit or a kidney punch and now you're peeing blood, really good indicator that the kidney injury may be more severe than maybe somebody had thought initially. So these are things that we can kind of look for at that secondary exam. Reassess your respiratory system, right? Is the airway maintained? Are we consistently patent? Are we getting good toluene volume? Do we have a good enough rate? Not too fast, not too slow. Look for those jugular veins. Is there something impeding blood flow back to the heart? Do we have tamponade developing? Is there tension pneumo developing? Do we have a flail chest with paradoxical movement? Recheck those bilateral breath sounds. Surveil your CO2 and SaO2 to let you know that these things are on the table and likely happening. Use your ECG to monitor your cardiac rhythm. Ventricular irritability is associated with cardiac contusion are one of the earliest signs that we can see. But also amplitude in cardiac tamponade can be an indicator that something's going on. But at the very least, it's the best way to consistently look and surveil for increasing tachyarrhythmias. Absent or radial pulses, obviously, shocked, capillary refill time delayed. These are all indications of what is decompensated shock at that point, right? Assess your neurological system. I would suggest in trauma patients, the best way to know that your perfusion is adequate is mentation. When your patient loses mentation, perfusion to the most sensitive organ, your brain, is not enough. Therefore, it's not enough to potentially to other organs as well. But if your brain's getting enough, so is everybody else in the short term, at least until we can plug the hole and get you some blood. Reassess these patients. Abnormal findings, when you have something that was mildly concerning in the primary, you got to reassess them. You got to hit them back, because it's either going to tell you, okay, it seems to be okay, or it's going to solidify that your instincts or your surveillance or your risk assessment was correct and spot on. Q5, that's a minimum for unstable patients, not a maximum, right? So I would suggest it's an ongoing surveillance and it's ongoing. You're consistently looking at ECG, you're consistently looking at your respiratory rate. So these are things that, Q5, really we're talking about an actual numerical blood pressure every 5 minutes is an absolute minimum on these patients that have this high risk assessment, or one that you had that big MOI and you're just waiting for them to show you. Standard precautions, look for signs of hyperperfusion. Get them out of there. You can't fix internal bleeding on your own. You need resources. You need that trauma surgeon and blood. So get them where they need to go. Psychological support. Why does it matter if the patient's calmer? Because if they're calmer, are they not going to dump less epi, less dopamine, less norepi? If they're in a significant amount of pain, they're going to dump more epi, more dopamine, more norepi. All of those things are contraindicated in bleeding, because they kill the patient. So if we're not being reassuring and we're not addressing their analgesic needs, we're actually helping them to die faster. So these are things we absolutely have to become really, really hyper aware of, right? When you see a trauma patient that's bleeding, you have to remember there's an epi, dopamine, and norepi drip right above their head, fictitious, right? And they have them going. They're showing you tachycardia and pain and anxiety and all these things, in which case we have to address those things to find out, hey, what is fear? What is pain? What is increasing hemorrhage, right? So that we're able to kind of delineate what's going on. Cover your sites, manage external bleeding, obviously ears, nose, throat. Don't pack anything. If bleeding from the ear is there, cup it, collect it, and control it, but don't pack it, because very often that could be a basal skull fracture, and that's your pressure relief valve. So we don't want to necessarily do that. But cover them loosely with sites. Make sure that we're controlling external bleeding when it's something certainly peripheral at the very least. Ears, eyes, nose, and throat again. Apply cold compresses to the nose. Any cold always causes vasoconstriction and will reduce bleeding. So bringing ice into bleeding, especially in your sense organs, it's just good practice, right? Check your blood pressure. Make sure you gauze it. Give it a medium by which to clot off more effectively and stop. That's certainly our goal. Hemorrhage, other areas control. Direct pressure works. Elevation, pressure tourniquet. Not going to be a new recipe. It's the same one when you're in EMT school, and it's not going to change. Tourniquets, useful for severe hemorrhage, right? If you find yourself with a significant femoral artery bleed in the groin, obviously it may be difficult or problematic with a traditional tourniquet. Figure out a way to get really good direct pressure there, get a good pressure dressing, and maintain even manual pressure if need be. Do not allow them to continue to bleed, because typically they're not going to do so well. CAT tourniquets are out there. I would suggest if you've never deployed a tourniquet and you expect to be proficient at it the first time you have to use it for a patient who's acutely arterial hemorrhaging in front of you, you're not going to be proficient. So you got to practice with these things. Be able to deploy it in 15 seconds, then be able to deploy it in the dark, and then be able to deploy it one-handed if necessary. because that's what's going to be necessary for you to do it at the point of contact when it's most needed and necessary in order to survive. A lot of different examples of stretch tourniquets, CAT tourniquets, multi-system, those are trauma ones. Several different, you have to be proficient for the ones that you're going to utilize, right? So if you're very good at 3 of them, but not the one you have, then you might as well not be good at any of them, right? So you have to be proficient at the equipment supplied you. So never meet your tourniquet the day you intend to stop bleeding, because it's too late. You have to be ahead of it. Rudimentary tourniquets, you're out there, you're not in a professional capacity, or your EMT didn't do good surveillance on your equipment, you didn't double check it, and therefore you don't have what you need. You can always make a makeshift tourniquet, right? Anything creating a circumferential and a twisting motion and ratcheting it down is going to get that done. Whether it be a patient's, yours, or a patient's belt can be utilized. Wide 4-inch dressing and then twisting is going to be able to stop. And certainly in the case of amputation, where it has to be quite quickly, this stuff works very, very well. Traditional commercial tourniquets, again, it's going to be job 1, that's going to work. Big axillary tourniquets, these work, right? Not a lot of people are buying them, but they're able to put femoral pressure, especially all those patients that have had caths or things and they have these pseudoaneurysms, or they're doing significant arterial bleeding at the femoral site. These are junctional tourniquets, right? And very often you'll see SWAT teams and sometimes specialized military units will carry these in order to basically compress those great vessels and just reduce blood supply to the entirety of the lower extremity if you have some significant, like, bilateral amputations, whatever the case may be. And it typically uses air pressure in order to keep these deep vessels just completely occluded. It works very well, but not typically utilized in your traditional EMS environments. Do not apply directly over a joint, right? Do not use the widest band possible. A very thin, that creates almost a piano wire effect, and obviously creating an amputation. So you want like that 4-inch width, right? Or more if you can get it, and then create that. That's going to be a better, more effective tourniquet. Use padding underneath, try not to go over the wound, right? Move up. Understand, especially in amputations or large trauma, these arteries are going to be vasoconstricting and they'll pull back in. So don't try to get right next to the margin of your big wound. Move up 3 or 4 inches. It's not going to cost them any extra tissue. It is going to cost them not having that artery pull beyond your tourniquet site and then creating a pseudoaneurysm, which may in fact be worse. Make sure that we're very demonstrative about our tourniquet placement. The fact that years ago, the actual thought was you put a T on their forehead so that we make sure that we address the tourniquet and it's not forgotten, in which case now it's gone past that diaphragm where we can survive that extremity. So obviously those are things we want to be hyper acutely aware of and make sure that we're loud and repetitive. Tourniquet over here, tourniquet over here. Make sure we're not putting something over the tourniquet where it's obscured. We want to make sure it's visible and it's in everybody's face. Broken bones, lacerated tissue obviously can cause bleeding. We want to mobilize those appropriately, stop the bleeding where indicated, and make sure that we're not doing, obviously, a bunch of direct pressure over a fractured site or something open. And if it's a large compound fracture with a bone out, let's make sure we're using adaptive dressing around that bone end, and then a traditional bulk dressing to keep that inside. We don't want that stuff going back in, but we don't want that bone marrow pulling stuff back into central circulation either. Splinting. Air splints work very well. I like the visualization of it. Makes you leave those fingers out, helps you with distal circulation and cap refill. You want to be able to continue to surveil those things because obviously anybody with a fracture has the ability to lose sensory circulation and motor beyond that structure. So we want to leave those the ability to kind of continually surveil our patients intact. Rigid splints, board splints, cardboard, there's 1,000 different kinds. The SAM splints, they're malleable and radio opaque. They're kind of nice if that's what your service provides you. But be familiar with what you have. Be familiar with its upsides, downsides, how to stabilize stuff, right? Traction splints, whether it be your Sagers, your hair tractions, a bunch of different brand names of getting the same thing done. You got that midline femur fracture, it's not open, you have no proximal or distal injury, then it's time to maybe deploy those things, right? To keep them reduction in pain, to keep them from further injury, and certainly stabilize those kinds of injuries that it's going to help you best. Hemostatic agents, all the rage, right? Everybody's got the new one, whether it be something systemic like TXE, a medication to cause you to acutely clot better and more proficiently, to this local stuff, hemostatic gauze or agents, even powders that you can pour into GSWs that allow you to completely clot off at the sites. Lots of chem exposure. Technology is supposed to make things better for us. This is just a way that we can maybe get better and better and better. Most of the stuff, studied in law enforcement, moves out to, studied in military, moves out to law enforcement, and then filters down into traditional EMS. So I think vitamin K impregnated dressings and all these other technologies and different kind of medicinal sources to help clotting be more efficient is certainly in the wheelhouse, and there's more being studied than even is available at this point. So it's going to be an ever-changing and increasing and bettering science as we go. Lightweight, they're easy to use, easy to store, easy to carry, conforms directly into the wound, doesn't cause any tissue necrosis or damage, easy to take off, doesn't spread to the rest of the system, it's localized. Typically big wins, right? These are kind of easy to sell, which is why they're a little expensive. Easy to sell and easy to want, it means you're going to pay for them. Complications, the powder it has infection risks. Embolus is certainly an issue, certainly with TXE or systemic administration of these medications. Foreign substance in the wound or the powder certainly can lead to clots and again, as an infection source. But these are minor. When you have what's on the other side of that is exsanguination, right? You have to pick your battles sometimes. Wound packing, particularly helpful. Junctional areas where you just open up gauze, don't even unroll it, just jam it into these large wounds. The more direct pressure you can get in packing these wounds and getting a good pressure dressing, the more likely they're going to do okay. I had a guy with right through his clavicle, chainsaw wound, directly through sternocleidomastoid muscle, through the clavicle, into his chest wall. Literally like all the gauze on the truck, large parama dressings just packed in there. Put this guy up, chicken winged into an ACE wrap, no bleeding whatsoever. Stopped his bleeding, he got to the OR, no complications, it went well. And this was a wound that looked like it could have been fatal with bleeding, and not a place you can do that traditional tourniquet. So using your imagination and more rather than less typically is a pretty good idea, especially for these large gaping type of awful wounds. Treatment of shock, obviously, internal hemorrhage, scary. It should always be scary for you because it's tenuous and it's always going to make you uncomfortable. Don't let them move around. We want them to pressure to go low on the leak, blood to become static, clot off, and no more bleeding, right? Your patient has a 78 blood pressure, but they're supine and they're maintaining that. Good, get them to the OR. We don't want to take them to 120 over 80, blow the clot loose and rinse out their arteries for them. That's not the team that we're supposed to be on. Surgery is going to be needed for those folks, so best to get them there hemodynamically stable versus just with a numerical that we like and a condition that we hate. That's the old thinking of Tredellenberg, and it's bad, right? So get 2 big IVs. Give nothing by mouth because we know they're going to surgery. Keep them warm, inclusive of even making a warm coil with a hot pack, or keeping your fluids warm. If you're using cold fluid replacement, then you're making your patient hypothermic, and we know that that's contraindicated and bad. So certainly analgesics, get them moving. Serial vital signs, but while you're moving towards the trauma center, not on scene. The more you have to do on scene, the less likely they get to where they need to be. Priorities, shock management, right? Circulation, then airway, then breathing, because without circulation, the other two are moved. Stop your major bleeding, ensure an airway, calm your patient down because we know tachycardia and catecholamine release is bad. Keep them supine. Don't let them drink, don't let them eat, don't let them move around. Moving around displaces those shocks. Keep your IV lines in place, but don't necessarily think that you have to utilize them because very often they can do more harm than good. Look at your ECG. If your patient starts to become ischemic and you start seeing ST depression, you start seeing PVCs or ventricular ectopy, look at that LOC. That's going to be maybe your biggest, most important factor is, are we mentating? Pulse and blood pressure as far as surveillance, going to tell you what they can. Shock is dynamic, but hemorrhagic shock, it's the easiest one to fix because we either stopped the bleeding or we didn't. And if we didn't, we got to get to where they can. Easy peasy kind of concept, and we have to just rely on it like it's fact. Because if we waste seconds and cells, it wasn't our cells and it wasn't our seconds to waste, and the patients have worse outcomes. This has been shock and trauma, bleeding management, part 2. Feel free to review part 1, and we're here for you.